This program is brought to you by Emory University.
Good morning, everyone. Welcome to another exciting Heart and Vascular Grand Rounds. We have one of our own, Dr. Peter Wilson, this morning. Dr. Wilson has been at Emory since 2006. He's a professor of medicine in the Division of Cardiology here at Emory and also professor of public health in epidemiology with Rollins Public Health. He's a director of epi and genomic medicine at the Atlanta VA Medical Center. He was previously professor of medicine at Medical University of South Carolina, professor of medicine at Boston University, and also the director of labs at Framingham Heart Study for more than 25 years. He is known as Mr. Framingham, at least in my that's how I introduce people. He is board certified in internal medicine and endocrinology. He's the author and co-author of more than 700 scientific articles and books. Recent research at the VA has focused on cardiometabolic population projects and genetics, especially with the Million Veterans Program. He has mentored more than 20 investigators over the past 20 years. He's actively involved in interviewing for our clinical investigator track. So thank you, Dr. Wilson, for that. I'm going to turn it over to him. He gives us our lipid update every few years, and looking forward to what you have to say, especially about lipoprotein A. I'll turn it over to you.
Yeah. Thanks very much, Pooja. So we'll get rolling here. I have no disclosures. We're going to start out with familial hypercholesterolemia, then talk some about lipid measurements, and then really focus on LDL cholesterol and triglycerides, then a few take-home points at the end. So, first of all, everybody should you always think you know these, but you should know the terms for all the xanthomas and the cholesterol deposits in the different parts of the bodies and their names. So xanthelasma comes from the Greek word for yellow, and xanthomas are in the tendons, and arcus cornei, we'll have pictures of all of these. So this is an example of xanthelasma. Not sure you can see my pointers, but it can be almost anywhere around the eyes. It's often a little bit on the lower edge or at the medial canthus. You might not see it on both sides. More and more people are getting plastic surgery early in their life, so they may be gone. You should think to ask if you don't see them and you are suspicious of very high cholesterol levels. Now, this is about the worst case you could get of tendinous xanthomas, the Achilles tendons. Get used to feeling for them and not just looking. And feel your own Achilles tendon, feel the Achilles tendon of younger people. You'll start to appreciate that it usually comes to a very sharp edge, and then you'll get rounding. These patients also are vulnerable for rupture. Of course, many people rupture just because of regular sports activity, but you get more fibrous tissue calcification, so they are more vulnerable for problems. These are tendinous xanthomas in the knuckles, in the hands, and get used to feeling for them, and make sure they're not syndesmophytes. They're not rheumatoid arthritis types of nodules. Uh, and they'll generally move when you have the person open and close their hands. This is not as common as it used to be, but it's something to also look for. This is Arcus cornei. It used to be called Arcus senilis. This is bilateral. This one goes pretty much all the way around 360 degrees. You might not see it at all going all the way around the circle. It's not very helpful as a marker for high cholesterol in people beyond 30 or 40 years of age and in people with darker pigmented skin. They're just more likely to develop Arcus. And then there are other common diseases. They're not so common, I guess. Wilson's disease, hypercalcemia, etc., that are associated with Arcus. So don't always think it's just because of a person's high cholesterol. Now, familial hypercholesterolemia has gotten more and more attention in the last 20 years because of medications to treat it and a lot of success. The top part I just mentioned, the genetics, we now have a greater appreciation that it is more common than we used to think. The prevalence of FH in the homozygous, the HO, and the heterozygous, the HEFH, is now down to the heterozygotes is more like 150 to 100, 1 out of 100 and 250. We used to think that was 1 out of 500. So it's more common than we used to think. You're not likely to see much homozygous FH. Those persons are generally picked up because they have severe skin abnormalities, the xanthomas and the other findings we were just showing you. They don't all have those findings, but almost all the homozygous patients do. The heterozygotes uh, don't, you might get some of the findings, but don't be surprised, especially with middle-aged and older patients, that there's no history. They just might not have any of those clinical findings that we talked about. So it really comes down to the LDL cholesterol and potentially other measures like apolipoprotein B. More and more, because of pediatric programs, they're getting picked up because of positive family history and what's called cascade screening. And that means if a family member's positive, the word is out and it's gotten around because of FH Foundation and other groups to screen other family members, especially the first degree family members, the blood relatives. And statins and cholesterol absorptions, everything is used pretty much in younger groups. You have to think about safety for the very youngest children. And then PCSK9 is generally reserved after all the oral medicines have been tried. And then LDL apheresis is especially used in homozygotes. Now, this is an example of collaboration in the Million Veteran Program with the 10 most common gene variants for FH, and this is for white veterans in MVP, Million Veteran Program. And this is just to show you that not everybody who has the genetic marker necessarily has a high LDL cholesterol. So this is from Jan-san, our collaborator here at the Rollins School of Public Health. And the most common variant, as you can see here to the far left, because of all these lines, and this is what's called a box and whiskers plot. The threshold for the adults is 190. But as you can see here, the average is typically a lot lower for those persons in that box. And as you go across, you can see some of the rare variants, it's like the one 7th or 8th over here to the right. Almost everybody has a high LDL cholesterol, but this is a less common variant. So there, do not always expect that a person who has the variant is going to have the gene and vice versa. And then you're going to say, if I know the person's phenotype, in other words, I know the LDL cholesterol untreated, do I need to do genetic testing? And in general, the answer is probably no. You don't really need to do that. This is another example of what's called a PheWAS, GWAS type of plot. And this takes all of the different types of tissues across on the x-axis going from left to right. And this is statistical significance going on the y-axis. As you can see on the top left, lipid abnormalities go along with the individuals who have the FH genes. They get heart disease at a lower frequency, but still highly statistically significant. And interestingly, they really don't tend to get much of any other types of complications across all the other different types of organ systems. What about now we're not going to spend too much more time. We'll on the medications talk some about FH medications and where we're going with that. But what about this is probably the most famous study in the world. Jerry Stamler's now 40, 50 years ago, almost, cholesterol in Mr. Fit screenees, multiple risk factor intervention trial screenees, largely 50-year-old men who were screened before they joined the trial, which had dietary, cholesterol, and blood pressure interventions. And the point was we take for granted, and that's true for most free living, healthy outpatients in who were recruited for studies like this. Uh, this is quintiles. And the bottom quintile starts at 182, so less than that. But now there's more and more data that's been accrued for these lower quintiles. And as you can see here, this is a fairly straight line and certainly going up. You could also say it's J-shaped. But what about lower levels? And that's been one of my areas of interest, and others have around the world. So this is one from the 7-country study, which was also similar, older vintage many years ago. And this was across 7 countries, regions, largely Western Europe and the States. And you have the same sort of thing. Now you're getting some data coming down to 125 milligrams per deciliter, especially when you get into Asian and European regions. But this is an example of some of the newest data that we have from the VA. And I'll just show you the focus on the different age group panels because it varies by age. So the top right is younger individuals, and this is a huge number of people. You see pretty much similar to what we were getting for MVP. I'm sorry, in MVP, what we were getting for Mr. Fit, but we're getting data now in the hundreds and even less than 100. And then you start to get some J-shape sort of swooping up at the very lowest levels for 45 to 64. And at the older individuals, it even goes up more. And others are replicating this. So individuals either on treatment or not on treatment, some people have very low cholesterols, and that is not necessarily a sign that they are in good health. Often goes along with frailty. And do not necessarily hold back your cholesterol treatment. If you think you believe they have atherosclerotic burden, you should probably go ahead and treat, because I'll show you other data to support that. You should also think of lifetime risk. Our newer guidances in the last 5-10 years, and the most recent Prevent 2024 also has lifetime risk estimates. This is one that now is more than 20 years old that Don Lloyd-Jones and I did, showing in Framingham, as you focus on these numbers. The numbers are in the 30% plus typically for women, and in the 40 to 50% plus for men. So men 50%, women 40% are the numbers that I especially for the higher levels. So people say, oh, I'm not going to get heart disease. Well, perhaps a person with a high atherosclerotic risk score, things like that, person with coronary artery calcification who is in their 40s, early 40s, perhaps 50. This is part of the message, the reason to treat those people going forward. Now, what about measurements? There are more measurements out there than we can imagine. These are the key measurements. The historic classic way to measure these lipids was using ultracentrifugation. And that's just generally only done in research labs, and it's not done very much anymore. And so you would have total cholesterol is what's in the entire tube, as you can see there. It's bracketed on the right. And you have HDL at the bottom. High density means it sinks. So it's at the bottom of the tube when you do ultracentrifugation. And very low density, VLDL, is at the top. And in between, you have the intermediate, and that's also where the LDL is right next to it. Separately, another way to do it, going beyond the lipid measures, is the apolipoprotein measures. So we have ApoA, which goes along with HDL, and ApoB, which goes along with the atherogenic particles, which are especially are LDL and IDL and some VLDL. ApoB continues to have enthusiasts. There are some very articulate scientists who have been pushing ApoB for the past 30 years. The measurements have gotten better and better. And when in doubt, if you're measuring and the LDL doesn't make sense to you or you're concerned, you can always double check an apolipoprotein B, and it'll give you another measure that'll help decide whether this person really has higher atherogenic lipids concentrations. Now, most lipids, we really want to get to LDL. At least this is America. We've been much more LDL cholesterol focused and using equations to estimate it. The most classic has been the Friedewald equation, and I highlighted that in the bottom. But now there are alternative equations. The Martin equation from Hopkins, the Sampson equation from NIH. Uh, I'm not sure it makes that much difference. If you have a printout on your whatever you've gotten from your local report, you can use all of these are very similar. Uh, Scott Grundy always likes to say the reason that these equations may be a little bit different are especially when you have higher triglycerides. And if you have higher triglycerides, Scott Grundy always makes the point, well, you have a triglyceride problem, often in addition to your LDL. And it's nice to measure, it's nice to think you have a number, but it might not be that accurate a number, no matter the equation that you use, because you're going to be working hard to actually reduce that number. Now, what about concentrations? So I'm just giving you some ballpark numbers here for adults and a couple for some children. Um, the average has been around 130 to 140 for both men and women. And for women, this is more after menopause, but for men, pretty much after age 30 to 60, you'll see 130 to 140 for the average American man. Typically 40 to 50 for HDL, higher for women. Women on estrogen products, especially OC pills, you may see it even higher. Women on equine estrogens or postmenopausal estrogen replacement, it may even be higher. VLDL is generally pretty low, and I've included these total numbers, and I also included one extra number here is the heterozygous FH cuts. So typically for adults, we use, as you can see here at the top, 190 milligrams per deciliter for adults. So that's a number, when you see that, it should ring a bell. You're going to be treating that patient more aggressively, especially focusing on lipids. And you're thinking at any age, after age 10, 15, 20, you're going to be probably aggressively treating that person with lifestyle, diet, and often medications. And I put here, because you're not so familiar with this number, what is the number that signals that you may have FH, heterozygous FH, in a pediatric or an adolescent? And the screening number is 200 total cholesterol. So once you get that, and you're going to get some screening numbers for college students or high schoolers, then go ahead and get the lipid profile. And if you don't treat those patients, go to one of our colleagues in pediatrics. And we've got them, Holly Gooding and others, who really are expert on this. So, you should think about both the total or the LDL. The total cholesterol is often used in equations because it's very accurate, and HDL because there's a mix. And this whole tableau of looking at both of them and thinking of both, historically, this started out even using the ratio, the total cholesterol to the HDL ratio. But it counts. It really does count. And what really counts is getting the LDL down along with other risk factors, reducing the smoking, controlling the blood pressure. Now, patients will ask, what about the determinants of LDL cholesterol? And what do I need to do? You'll hear about somebody who says, well, I eat an egg every day. Should that make a difference? I'll tell you, that's been controversial even after 40 years of research for diet. So the AHA has not come down real strongly on reducing egg consumption for patients who have moderately high cholesterol, because the data have been going both ways, so to speak. And now, a person eating a tremendous number of eggs, of course, you would recommend that they reduce that. But more importantly has been the saturated fat. Higher saturated fat in the diet is just not good for LDL cholesterol levels, and you should be encouraging patients to have more polyfat. And then I put there at the bottom as well estrogen status. So women, as they go through menopause, in general, the LDL cholesterol goes up. And that's one of the other determinants, because androgens and estrogens both have effects on LDL cholesterol. And the women, for instance, the men, as the boys, as they're entering puberty, that's when their HDL starts to drop. So you have estrogens and androgens having effect on both LDL and HDL. And the next one's going to be here. the HDL impact. So who are the people who have the highest HDL in the clinic? And I always say that because that's easier to remember. So it's the thin woman who goes to the exercise club and has a little bit of alcohol. That's, as you can see, scanning right down. Female estrogens, thin, no cigarettes. Actually, there is a negative impact of cigarettes on HDL. A little bit of alcohol is a little bit favorable. That person's exercising. And then of course, there are genetic variants. Some people will say, well, what about, well, let's have the HDL higher and higher and the better and better. There are some genetic variants that are associated with HDL. It's hard to get over 80 without being a genetic variant. The other group that's over 80 and they do not necessarily have very good cardiovascular health is very high intake alcohol. So studies have been done for individuals who have gone to rehab centers with very high HDL, and those people have been tracked for heart disease risk, and it's generally increased. Now, I have to say something about diet. I know that that's the cornerstone at the starting point is lifestyle and diet. Uh, I listed all these diets because virtually every one of these diets has been associated with cardiovascular risk reduction. Isn't that hard to believe? And look at all the variants. Have tremendous differences in carbohydrates, not that much difference in protein, as you can see, not that much. There is big difference in fats, and virtually everything except the Atkins has been discouraging saturated fat. So part of the message, of course, with our diet prescription for our patients is reduction in calories. Almost every day I even heard on the news today, the fraction of Americans or people in Georgia who are obese. In general, the numbers keep increasing. We have a third at normal weight. We have a third who are overweight, and then a third who are frankly obese. And the obese group is growing, and the super obese, those with BMIs 35 plus and 40 plus, is also growing even faster than almost any of the other groups. But the ATP3 here in the Women's Health Initiative, the WHI, as you see there, that's sort of after a couple below the Atkins and Jerry Reven's diet. Those diets are all the same. They're virtually all the same. They just have different names. And then people will say, well, I don't know about the American Heart Association diet, but I like the Zone diet. And then if you look at this and you say, gee, they're really about the same. Fine. And what about the DASH diet? Like the folks who have been doing all those big trials, like Larry Apple and Frank Sachs. Yep. Well, that's pretty much like the American Heart Association diet too. So they're all those cluster, most of those in the center, they're all more similar than they are. There aren't any major differences. So go work with your patients, especially if they're interested in this. But these extreme diets, and we'll all meet those individuals who get convinced that they want to be on an extreme diet. They should watch out, especially if they get on an extreme diet, like a ketogenic diet or something like that. And then their lipids don't do well, or their glycemic control doesn't do well, or they have other complications. Now, this is a number that you should look at the bottom line. We should all know a couple of these numbers. This is the meta-analysis from the clinical trialists group out of the United Kingdom, and it shows the lipid effects for 1 millimole. So 1 millimole's 38 to 40 difference, and that's typically what you would get with a good entry-level statin dose, entry to mid-level statin dose. And as you can see there, 0.78, so a 22% reduction in lipids. So that's overall, and that's generally the older data. So it's more than that. It's more than 22% in the modern era. That is the sort of a starting dose in what I would say in the more recent era. And then this is the other number, is death, mortality as a 10%, as you can see, also bottom line, a 10% decrease in death. And some of these don't come through quite as strong, and then some of the trials, as you can see at the top, they were not focusing on death. So you have to be very careful trying to interpret any big meta-analysis for all the different endpoints, because some trials were actually geared towards preventing the first event, like angina or stenting or coronary or myocardial infarction, and they were not trying to prevent death. So not all the trials will have quite the same impact on death. This is a more recent one. This is a paper that I was involved with also from the VA. And there's a major NIH trial, PCORI trial also, leading into this is what about after age 75, as you can see here at the top. And in the VA, this is observational using the most modern methods nobody was on medication at the start of the observation interval, but for all groups, male, female, white, black, other, all ages greater than 75, diabetes, yes, no, all of these individuals benefited by being on a statin over after age 75. And the PCORI trial should help to provide even more universal results on this same topic. And they haven't released their results yet. That trial still underway. All right, so summary, how do we approach diet and et cetera, moving down to lower LDL for our patients? I have patients all the time, when I'm in clinic, they say, "I'm really gonna lower it with diet." The studies that have done it have generally found 5 to 15%. The really enthusiastic diet trials that, Mediterranean diet may be better, but they're in Mediterranean areas and they're not really trials, they're observational studies. But I still say 5 to 15% in the clinic all the time. Typically, we're getting much more. And in the modern era, 30 to 50% with statins. I think all of you know that. And then you'll have patients who will bargain with you and they say, well, I'm taking a very potent statin. Maybe I don't need to worry about my diet. I don't have an answer to them for that. The more important thing, they are right, is in the modern era is to take the statin. The trials that used to have diet plus statin effects are no longer really being undertaken. We all believe they would show a minor effect, but if you're getting 40 to 50% plus with a high dose of a statin, the diet does become a secondary issue. Of course, but then you've got to follow the patient and make sure they're safely taking it and not having complications. Now, these older drugs, you should be at least aware of for those patients who have statin intolerance or partial intolerance. Uh, all of these drugs have generally shown some elements of cholesterol lowering, as you can see here, and I'll have other slides that'll give you some of these summaries. But as you can see, most of them are 20% effects or in that range, but they gotten pushed aside because of the 30% for most statins. And for patients who have statin partial intolerance, low dose statins often have more than what you can see for these other oral drugs. And injectable therapy, most clinicians who are actively in the preventive cardiology business, so to speak, are using these two first PCSK9 drugs. These are injectables. I've not seen data yet, but I know that there are oral versions of PCSK9 that are in trial mode, and I have not seen results on that yet. Hopefully in the next meetings to come, we will. But the PCSK9s over and above the statins are 40 to 50% drugs. So you start out with somebody, for instance, let's say who had that LDL of 200, let's say. So he meets the heterozygous FH criteria and he's on a full dose statin, we get him to 100. But then if he has coronary disease, you can see he then, well, how about even more? So you would move towards a PCSK9 to get him underneath the goal that's typically used in the States of 70 and some parts even 50 milligrams per deciliter. So this is on top of a statin. And then moving along, also we now have newer versions, also with a PCSK9, the inclisiran, which is more of a, it becomes the first year it's a 3 times injection done at the clinic, not at home. These other medicines are auto injectors done at home, but these medicines are similar in potency, but there's going to be with positive trials, these are going to be even more enthusiastically embraced because you don't have to take the medicine as often. And then finally, apheresis, which is generally reserved for severe heterozygotes, and for homozygotes, you also get this, and you have to do it on a very regular interval. So now this grid, most clinicians who are in preventive cardiology are aware of. We are generally in with patients who have active disease or a very high risk. We're reaching for the two most potent statins, atorvastatin, rosuvastatin, but we become aware of all of these others as well. And there's a lot less use, but there is sometimes use of all of these statins that are in this tableau, including the very oldest ones. So it's good to have familiarity. And also, I think more and more what's happening for lipidologists is when patients have trouble with atorvastatin and rosuvastatin, they're reaching a little bit more for pitavastatin. At the highest dose of pitavastatin, it certainly gets up closer to the higher intensity, and it has a different mechanism of breakdown in the body. So it's often tolerated when atorva or rosuva are not tolerated. Now, where do statins work and where do they not work? The top, I think you're all aware of. All ASCVD events. Also, it prevents amputation in patients with peripheral artery disease. And Paul Ridker, Paul has done so many different things. He's also was the first to show it prevented deep venous thrombosis. The mechanism's not entirely known, but it works there. Where does it not work? It doesn't work for heart failure. It doesn't work for calcified valves. Once you have an oxidized lipids and it's sitting on a valve, the statin medications are just not affecting it. Once you also have a positive CAC score, don't expect the CAC score to improve when you're taking a statin. Often it may get a little worse. Also, there's when should you repeat the CAC score? From my colleagues that I hang out with at meetings, they generally are saying 5 years from this. That's mostly from the Hopkins group, preventive cardiology, Roger Blumenthal and colleagues. And then it says here also not, and this is true because of some trials, not to treat statin patients, use statins in dialysis patients. Well, don't start the statins in dialysis patients. But if you already have a person with chronic kidney disease and they're on a statin, all of us would say you're not going to stop the statin in the dialysis patients. So it's not been effective if you start late, but if you're not going to discontinue it for a person who has worsening CKD and then goes on dialysis. And I think that's more word of mouth and rule of thumb and art of medicine. And there's not a lot of data on that topic. But what about complications? One of them's diabetes for sure. Naveed Sattar in Glasgow has done this meta-analysis, and it's not really been updated I haven't found one, but this is where most people still think it is. It's around a 10%, 1.909, 9% increase across all these big trials. Paul Ridker as well within the Jupiter trial did what I would call sort of an explosion analysis across all the metabolic syndrome traits. And remember, each of those metabolic syndrome traits can also increase risk of developing diabetes mellitus. So this is a 10%er, but also look for the person who has metabolic syndrome who you're putting on a statin. Though each one of those traits is likely to increase the risk even further to develop diabetes if the person started out as a non-diabetic when they were beginning the medicines. Now, Dr. Ridker is leading the charge more than anybody probably.
You put a CS form?
In the States and in the world for chronic inflammatory risk reduction, statins and immunotherapy. So this was methotrexate. This was an interleukin-1 beta blocker. And this was positive. They were very enthusiastic. Unfortunately, the methotrexate trial was null. He's still exploring other molecules. I haven't seen a new trial yet that is addressing this, but this is an issue that he is more than anybody is gonna, and keep your eyes out for what he's doing next, is beyond lipid lowering, what about reducing inflammation, especially interleukins, IL-1, IL-6, and C-reactive protein as an integrative measure? Now, what about the latest drugs, and what is the mechanism? Where do they work? So this is a liver cell to give you the feeling. As over here, you have different molecules being made. Some of the drugs that were being made here, for instance, mycosomal transfer protein, there is a drug here to treat mipomersen works here at this mechanism, but it's associated with fatty liver. So this is the supply side where you make a VLDL particle, it gets released, it gets modified with cholesterol ester transfer protein. It comes back as an LDL. And this is where the PCSK9s are work. The PCSK9s are then help to metabolize the LDL particles, come back, and then they are degraded. So what are the medicines doing that are your PCSK9 drugs? They are increasing the lifespan. I think the best way to think about it is the life cycle, so to speak, of your LDL receptor degradation pathway. So they just, your receptors are going to last longer. They're going to break down the LDL particles. They're going to take them back into the liver, and they're going to get rid of them more effectively because you've got the PCSK9 injectables. So this is going to continue. All of these, the latest one, inclisiran works more over here, and then the PCSK9s that we actually have every 2 weeks work more up here at the LDL receptor mechanism. Now, let me say a few words. Our colleague, Larry Sperling, has been on the Prevent 2024 group, and so we hear from that. But if I'm giving a talk on lipid lowering, I need to say a little bit, where are we vis-a-vis the 2018-19 guidelines and the 2024? So it's pretty much the same. Everybody who is heterozygous gets treated aggressively. We're still talking about 10 years of risk. It goes back to the 2014 equations, some updates with the 2018, and now even further updates with, as you see down here in the bottom, with the 2024. So in 2018, I'll give you the list of the risk enhancing factors, which is pretty long and it's well known to most preventive cardiologists, and as well the coronary artery CAC scoring possibility. And the Hopkins scientists especially have popularized the value of the power of zero. If you have a CAC of zero, that can help downgrade your risk. The difference in the newest algorithm is having a kidney function with you taking a serum creatinine and estimating glomerular filtration rate. Also for diabetic or kidney patients, urinary albumin to creatinine ratio, and for diabetics, hemoglobin A1C. Now, you do not need, if you use Prevent 2024, there's sort of the Prevent 2024 simple version, and then there's more extended version. This is especially the kidney and the glucose function are important for patients with diabetes and those with kidney disease, or both of those. For patients who don't have either of those, you can probably do quite well with a simpler version of the Prevent 2024, or you could potentially go back to the pooled cohort equations that are available from 2018 with the AES CVD Plus that you can get on your smartphone. Okay, and then these are the percentages. I'm not going to dwell on this. I want to say we keep changing these, and this is going to change some with what are the cutoffs to treat, because the Prevent 2024 is providing lower risk estimates because it's based on more modern data than what was used for the 2014 and the 2018. So keep an eye out for that. We haven't gotten a total new algorithm guidance from ACC, AHA. I wouldn't be surprised that's going to be coming around the corner in the next few years, though. And then here's that list of risk enhancing factors. We know if you think somebody has one of these, just go through the list, and most of us know the list already. It's inflammatory diseases, high C-reactive protein, a high LP(a), we'll get to that in a little bit, other issues, positive family history, etc. Now, let me say a word about CAC. So those who are, comes through all the time. Consider no statin if you have a CAC of 0. In other words, do the risk, but then this will help downgrade risk. And if you want to read the original articles, it's especially becomes out of the MESA study and Hopkins scientists and others, but people like Mike Blaha and others at Johns Hopkins, especially read those articles. What about adverse effects on statins? Now, everybody who treats has got myalgia patients. I got a clinic full of myalgia patients because I'm in a referral clinic. And the next thing is I go to a statin that I think will do the job for that patient, the degree of lowering that they need. And I usually try to stay with a potent statin, especially for patients with coronary disease. And I will go low. And going low, what's the lowest you can go? I can go on my lowest is 5 milligrams of rosuvastatin a week and 5 or 10 of atorva a week. So I often start the patient on a medicine, and then I say, if you have side effects, the muscle aches or this or that, and you think it might be related to the statin, take a statin holiday, which is 3 to 5 days of no statins. You take your other medicines, and then you start back. And you start back on the same dose of statin you were just on, or you reduce the dose. Success is having some degree of lowering on some degree of statin. And this has been written up by others. Bob Eckel in Colorado, former president of AHA, former president of American Diabetes Association's written about this. Others have written about it as well, but it works. A low dose can definitely work. Now, myositis in general, this is uncommon, 5 times upper limit of normal of CKs. That generally knocks you out for at least that statin and typically statins. And whoops, I want to go back. In general, and rhabdomyolysis very definitely knocks you out. And then keep an eye also on liver function abnormalities. We typically say that when you're going to get the liver function abnormalities, it's likely to occur in the first 3 months, especially in the first year, but it can occur later. It really can occur later. And an annual chem profile will help just pick this up. And you stop, and in general, it's a drug-induced liver injury that goes right back to normal with stopping the statin. So. These are other side effects. Those of you who are older know that bile acid resins cause constipation. Nicotinic acid works by prostaglandin D mechanism, is associated with flushing. This can be mitigated with taking aspirin and taking it with food and taking it late at night, and so you don't flush around other people. So you flush by yourself, and you don't get self-conscious about it. This one's associated with gout. So is bempedoic acid, the newer medication. So this has got a greater association with gout, the bempedoic acid. And then finally, PCSK9. What should you say to patients who are taking that? First of all, when you take PCSK9, I tell patients you're taking it at 3 o'clock and 9 o'clock, close to the abdomen for the most part, maybe anterior thigh, but not lateral thigh, to reduce any site reactions and not to inject it into muscle or into fibrous tissue. And in general, we don't have much in the way of site reactions, and I've got hundreds of patients on this over time. Flu-like illness, though, if they have a flu-like illness within 24 hours of taking a PCSK9, they find generally can start up again, but they'll skip the next dose. So their next shot will be a month from then, not 2 weeks from then. So you'll skip that one next dose that was planned. Now we're getting close to the end here, and then this is Lp(a), the molecule probably of this year and next year for lipids, because we don't have very effective treatments up till now. and it's a game changer as new molecules are being created. The big issue is how effective will they be in preventing atherosclerotic events. So at the core here is an LDL molecule, and then around it is a protein, and this is apolipoprotein little a apolipoprotein, and then a little a inside parentheses, all right? And these are shaped in little, little twists. And the person who discovered this is Kari Berg, and Dr. Berg is Swedish, and these are in the shape of Swedish pastries that they call kringles. Bless him. So these are all now called kringles because he thought of that. And and there are many repeats, and this is the genetic part of it that it makes this much more atherogenic and susceptible to oxidization. And this is just another measure. When you measure your LDL cholesterol, you're getting a little bit of this molecule, but the way to really I understand it is to measure the whole molecule. You could measure the apo little a, but now they're measuring the whole molecule. So LP little a, as you see here at the top, now has measurements, okay? So who should get measured? Anybody with early onset ASCVD. More and more people are saying perhaps almost everybody, for sure. And any arterial disease. Question persons with venous disease like DVT in your 20s and 30s. There's some debate now whether we've always thought historically that this was associated with increased arterial and venous disease. This is being debated a little bit whether there's definitely a signal for venous disease. It's highly heritable. Of all the lipids, it's the most genetically associated. It's much higher levels across the groups that have African ancestry. It runs in families, and it's an acute phase reactant. So person just had a heart attack and they're in the ICU. That's not a good time to measure it because you may give you a false number. So because it's an acute phase reactant. The best time is when they're at one of their regular outpatient visits. So here are some of the distributions. Here we have white individuals at the top panel and then blacks. As you can see, it's much more of a normal distribution in blacks. And these are these are higher levels compared to, it's a skewed J-shaped relationship in the white individuals. And you'll see different levels. You'll see nanomoles in milligrams per deciliter. It's not easily convertible. And if you're going to be, don't bounce around with the same patient at different hospitals. In other words, stay with one lab so you're always interpreting the units. And typically what I do is you figure out what is the upper limit of normal, and then I often will say X times the upper limit of normal, because a lot of them in the normal range, you're not going to make that much of a difference. Now, this is some of what I was talking about for acute phase reactant. On the left panel are percentage effects, on the right are multiplier effects. A bunch of dietary changes, exercise. Here you can see sepsis in this big panel can really drop your LP little a. So, hey, don't measure it in your acutely ill patients who just got hospitalized. And then other things can raise it. So certain things, as you can see, kidney disease, some other hormonal effects. So pay attention. The time to do it is when you're getting a regular lipid panel as an outpatient. They need not be fasting. Now, this is the panel you're going to, I think I have a build here. Hold on. Yeah, there we go. So the top are all the medicines that we have had lots of experience with, and some of them less experience, like the PCSK9. These medicines, with the exception of those working on the PCSK9 in the upper third here, they don't do much. So statins in general, it goes up. It goes the wrong direction. It's not going down. So you want a negative number. And as you can see, around a 25% across the PCSK9s. But the medicines that are under development, and we haven't seen the trial results, are much stronger movers of the LP little a concentrations. Historically, the other one has been nicotinic acid. Unfortunately, of course, we've had trials with statin plus nicotinic acid, and they were null. So they didn't isolate the Lp(a) effects within those trials, and they weren't targeting those individuals. But this is where the promise is in the future. What's going to happen with these new molecules in the new trials? All right, and that's all I'm going to say about Lp(a), and then we're going to finish up here the last few minutes about triglycerides. Because if I don't say anything about triglycerides, you'll sort of say he didn't say anything, and I have a bunch of patients with that. So these are eruptive xanthomas. You may see them on the knees. You may see them on the buttocks, on the back. They tend to go in certain places. You may have some patients with extremely high triglyceride levels, and they don't have these at all. I'm not sure who gets them and who doesn't get the eruptive xanthomas, but not everybody gets them who has very high levels. And then this one's got some labels here. Here, I'll give you all the labels. So these are the same eruptive xanthomas. This is lipemic plasma, TGs over 1,000. The most common patients in the hospital who have this are diabetic ketoacidosis. When you have no insulin on board, you don't have lipoprotein lipase to clear TGs, and you get lipemic plasma. This goes away very fast in the next few days for teenagers with DKA. Lipemia retinalis, if you're looking in the retina for somebody with high TGs. Palmar crease striae may not see this extremely well, but you see it across the streets here. You can see this with super high cholesterol. You can see this with some other dyslipidemias as well, and then some tuberous xanthomas as well. You can see any of these possibilities in these patients. So this is the general strategy. Is to first, if they're over 1,000, you get them less than 1,000 because you want to reduce pancreatitis risk. If they're a 500 to 1,000, you want to get them less than 500 to reduce ASCVD risk. And you want to keep them under 500. So the medicines that you've used up here at the top, if you're using medicines, and you usually are with these very high levels, you're going to continue. And then when you get less than 170, this is where the controversy is. How low do I need to go? So if you've got a person with TGs of 200 to 500 and a moderately high LDL, actually the answer to treat is to be very aggressive with the statins and the LDL cholesterol lowering, and secondarily consider a strategy to lower triglycerides, which would be lifestyle plus medicines. So lifestyle is always important for triglycerides, and there are a whole variety of effects here: carbs, fats, alcohol, reduce weight, and if a person, especially those who are on insulin and not poorly controlled, to control the insulin better, because then you upregulate lipoprotein lipase and you'll help clear the triglycerides from the diet. Now, here are the effects of the triglycerides. Time-honored are fibrates. So the first in the United States that we've used the most is gemfibrozole, which is Lipid, and then the other one is fenofibrate. Fenofibrate is a little better tolerated and have fewer side effects when you also have a statin on board. So there's, in general, more of a preference towards fenofibrate rather than gemfibrozole for persons who are also taking LDL lowering medications. But as you can see here also, you have niacin, nicotinic acid has the effects. And I'll come back to the omega-3 in a sec. You always have some effects, especially with the highest dose of the statin, but not big effects, and then a mild effect with the ezetimibe. But to come back to omega-3s. So omega-3s is, most people are underdosing omega-3. You'll have patients who will say, I got omega-3 or I got fish oil products at the health food store. Well, they should show you the bottle that they have, because a lot of it will say fish oil or omega-3, and it might not have much in it. You want active ingredient, and there's EPA and DHA, the two types of omega-3s. What counts is the total of 4 grams a day for real lowering. So the patients often I have with the TGs over 1,000, they'll be on both an omega-3 plus a fibrate. That's the typical cornerstone. Somebody who, and then I get them down, and I usually will try to drop this, because this ends up being a lot of pills a day. This is 8 pills a day to get this amount of omega-3, and the fenofibrate's just 1 pill a day. So once I get them down, hopefully I can get them off the omega-3 and they just continue with the fibrate to keep their TGs under 500 for sure. And I think that's some of what I was just talking about, but let me just show you here. Now, we've had some trials, but in the modern era, we got to recognize we have statin trials, and then we add medicines to statins. So the most recent one that had omega-3s, especially, this is omega-3 summary, is the Reduce It trial, which was released about 5 to 8 years ago. Deepak Bhatt, when he was at Harvard, now in New York, was the first author, New England Journal, in Reduce It trial, and it reduced MACE by 25%. Now, the problem with that is they probably did not have a really effective or neutral, I would say, the neutral control arm of the trial. So think of it this way. Not that I'm exactly right, but I'm going to show you a supporting slide in a next couple of slides, is that the medicine reduced the risk by about 10 to 15%. But the control arm, it was not a normal control arm because they had mineral oil in this trial, and it increased the risk 10 to 15%. So the overall delta was 25%. It was a positive trial. And well, why did Dr. Wilson say that? Because of this result, and this is Paul Ridker's group with a post hoc analysis. They got the specimens from the Reduce It trial, and these are the lipid changes 12 months after the trial was underway. They got those specimens, and virtually all the things that were measured post hoc, these inflammatory markers, other things, lipids went up 11%, CRP went up 22%. Everything was statistically significant. So that supports the argument that sure, the medicine had a reduction in risk, but there was an adverse effect because of what was going on, as you can see here in the comparator group, the mineral oil, they had unfavorable effects in these biomarkers. So, all right, that's highlighted there. All right, last slide. So what are some of the take-home points? We should always include diet and lifestyle, not only just for lipids, also for other things, also for diabetes, also for triglycerides. LDL has a minor effect, but this is a cornerstone for virtually everything. I think you got to start out, for instance, when you're concerned about lipids, is first you got to measure them. Second, you got to have diet and lifestyle, and then you have medicines. And then so you're thinking also of the family as you're going forward and who else is in the household. So the statins have become the cornerstone, and I think virtually everybody who's in preventive cardiology is aware of that. Just a few of the pearls that I find helpful is in general, most preventive cardiologists are going to be sticking with the more or most potent statins. Titrate as needed, even using very low dosing, considering statin holidays as needed. The second drug to add typically, and this is in virtually all the guidelines from AHA, ACC, American Diabetes, is ezetimibe. That may change. There may be others to be added depending upon the results of evidence and trials. And then PCSK9 injectables. And this is now these drugs are getting older. I'd like to think as there gets more competition, number one, perhaps the costs will come down and will not become so much of a burden to get it approved for patients. And then I'm hopeful that this will become an oral medication as well, which ought to reduce the costs. And then around the corner is Lp(a), and we particularly may have some other medicines for individuals, especially with high Lp(a) on top of the statin and perhaps other LDL interventions. We're going to have an Lp(a) intervention where it's needed. So thanks very much.
Great. Thank you so much, Dr. Wilson, for a very comprehensive talk this morning on current strategies for lipid management. I really appreciate your time this morning. It is past 8:30, so if anybody has any questions, we can take a couple. Go ahead and put them in the chat or go ahead and unmute. We have a question from Dr. Walker. How low is too low when it comes to LDL? Had a clinic patient with multiple risk factors. LDL was 9 on PCSK9.
Yeah. So the question is low, and some of the earliest trials uh, actually backed out of very aggressive LDL cholesterol. Once they got around 25 or so, they started to ease up on the therapy. There has not been any negative signal. The one thing that, at least to remember, is the LDL particle is carrying fat-soluble vitamins. And so the fat-soluble vitamins are K, A, D, and E. There's not been any signal we know of so far for anything associated with vitamin K. The concern would be retinitis pigmentosa or night blindness. Vitamin A is also, I'm sorry, that was A. Vitamin K would be warfarin, and there's not been any problem for patients on warfarin for bleeding disorders. Vitamin E for sure has been measured, and there are ancillary pathways for E and A, and that's not been a problem. The only one that's a little bit lingering, and I haven't seen any data, is vitamin D. So are women, especially long term, are they going to be vulnerable to osteoporosis? Nobody's done it. So I think you need a whole bunch more data. But the one thing I also recommend to patients is to take multivitamins for those who are in that extremely low club of LDLs under 50. It doesn't hurt. Just go out and get a multivitamin, and most of them have the fat soluble vitamins. But other than that, the other is don't pay too much attention to the number because it's not very accurate. Once you take the same specimen tomorrow, and it may be 30. So it's hard to measure down there.
Okay, thank you. Dr. Smith has a question. What about the impact of GLP-1 agonists?
On lipids, is that what I guess
Yes,
that's the
yes,
question?
yes.
Yeah. So you'd like to think it's going to be better. I don't know the data though. I'll be honest with you. So what he's talking about is good weight reduction for a person's long term over time with taking a GLP-1 receptor agonist therapy that will cause the person to lose weight. Now, short term you might get almost anything as you're losing the weight. And in general, when anybody rapidly loses weight, often they have their LDL cholesterol go down. That's another thing. Is somebody who's just had a major weight loss program, you're going to the lipids will look better than you think they are. You wait until they've leveled out and repeat it, because often they're not going to keep going down. So get used to where the person is in the steady state. But I'm not aware of any adverse effect here. But I would like to think triglycerides would likely come down with weight loss. But can't make any prediction for the LDL unless others have data. No, I haven't seen it.
Okay, any other questions? So Dr. Wilson, if somebody has a high LPA, that is in the primary prevention setting with sort of borderline high LDLs, do you think that we should just go directly to PCSK9 right now instead of going through the whole statin, Zetia, and then PCSK9?
Right. So the question is, can you get an approval for a PCSK9 because of a 25% reduction in Lp(a) for a person with, I guess what you're assuming, wanting me to assume is a normal LDL cholesterol.
Mhm.
I've had that discussion with my PharmD at the VA, and the PharmD will not approve it. So, um, so now, outside the VA, you'd have to deal with a benefits person, and I don't know whether they will approve it either. But
Mhm.
I think we're going to be there in a year or two.
Right.
And the other issue is what is going to be the cost of the LP little of the medicine, and what's going to be the cost of the new LP(a) medicines as well. So they're going to, if the person has a moderate to increased LDL cholesterol, it's easier to justify. But so you have an LDL and you have an Lp(a). If the person is a 20-year-old and simply has high Lp(a), it's hard to justify. So what would you do right now? One of the things you could do now is, of course, if it's a younger person and has an isolated high Lp(a), is you could go ahead and do some non-invasive testing on it, or you could do an imaging. You could do a CAC score on it. That might help you. You could also, I didn't mention this, but Lp(a) is also associated with the development of aortic stenosis. Either the gene or the higher level, those persons are more likely. And there is in the works, the companies that are making these new products are developing studies that are going to potentially treat early persons with LPA genes or high Lp(a) to prevent aortic valve disease, stenotic disease over time. But I think those are going to be long-term trials. They're not going to happen overnight at all. So.
Mhm. All right. Thank you so much. Since we're getting close to about 10 minutes past, thank you again, everyone, for joining. Don't forget to get your CME credit. And thank you, Dr. Wilson, again for the time. We got through it. You were able to share in advance. This was great. Thank you so much.
Thanks. Take care.
Thank you.
The preceding program is copyrighted by Emory University.